Dr. Gordon Slater, welcome to Project 100, mate.
Thanks, Mark. Great to be here. Thanks for the opportunity.
I guess I should tell everybody how I know this dude. I was actually just finishing my jiu-jitsu session and in the cross, and with my old mate Larry Papadopoulos, and Larry's next session was with this bloke in a pair of shorts and t-shirt and a beard, and it was a pad session. And Larry said, you should talk to this guy because I have an injury, okay? So I have an injury. I've always got a fucking injury, but I've got an injury, right? And Larry said, you should talk to this guy. He's an orthopaedic surgeon, and he knows about, obviously, muscle tears, all that sort of stuff. In which case, I waited for you to finish his session, and then we started talking. We started talking about hyperbaric chambers and oxygen. So
Yes.
What do you call it? HBOT.
HBOT, that's right.
Hyperbaric Oxygen
Therapy.
Therapy.
Oxygen
There we
therapy.
go. Now I got a bit fascinated because I get fascinated by these things. Anyway, I'll leave that part. That's how I know him. I'll leave that part right to them. We'll talk about that stuff and what my experience has been with it. We'll come back to that. But I just want to introduce how I met the guy. That's the first thing. I also remember, I don't know what, but I'm sure before I met you, I had seen Instagram stuff from you. Would that be right?
Yes. Yeah, we've had some Instagram posts on it.
Yeah, and
That's
somehow
right.
it's found its way to me.
Right, okay.
And probably because Instagram profiles people and knows I'm interested in this sort of stuff, and you must be
Right.
talking about regenerative medicine. You must be talking about longevity and probably talking about other stuff that I'm interested in. So somehow I found its way to me, and I knew your name, but I couldn't remember where I knew your name from. Our tradition on the show is we ask our guests to just give us a bit of an idea what their, let's call it, academic and professional qualifications are. So do you mind telling us what they are?
Yeah, sure. So I'm an Australian-trained orthopaedic surgeon. I've got an interest in foot and ankle surgery. I'm trained at HSS, which is Hospital for Special Surgery in New York, and I've had a very long relationship with them. And I guess that my interest in hyperbaric oxygen therapy has stemmed from that. So I've written lots of papers with the guys in New York, and a great mate of mine, Marty O'Malley, a couple of years ago said, I'm starting up a business, MD Hyperbaric in New York, and we're going to start to treat our pro athletes with hyperbaric oxygen and general people. And I said to him, well, I don't think that works. And he said, well, come over and take a look. So I guess academically, trained in Australia, the Australian program. I've trained overseas in France, in Edinburgh, and also in New York.
In orthopaedics.
In orthopaedics.
In other words, surgery.
That's right.
Yep.
And I've just taken up a professorship at University of Technology, Sydney.
And what is that, a teaching role or is that a research role?
Combination. So teaching, just starting up the lecture program. So I've had a couple of their students through already, and we sponsor primarily one of their students who's a biomedical engineer. So I'm in the biomedical section of the university. Which
is the combination of the faculty of medicine and engineering.
Yeah, they don't actually have they don't have a medical degree at UTS, but they have biomedical. So they have like a range of different things in that space. So I'm trying to push a regenerative medicine focus, but that will be primarily from a biomedical point of view.
So fair to say that you are a student of regenerative medicine as such. Also, you're a student of orthopedic surgery, which is what you do day to day. But you're
That's
also
right.
a student of what apparatuses, what engineered things like machines, which is where the engineering part comes in, can do to us in terms of helping us get better.
Yeah, that's exactly right. And orthopedics uses a lot of mechanical devices, hip replacement or knee replacement. They're mechanical things, as are external fixators. So we do have an engineering component in orthopedics.
Yeah, that's interesting. Sometimes people forget what an orthopedic surgeon does, but basically they use all these tools. My brother recently had a hip operation and a knee operation, knee replacement, hip replacement, and I was talking to his surgeon at St. Vincent's, and he was basically telling me how he did the surgery, and my God, like he literally cut his leg at the top part of your leg off and at the bottom part of your leg off and took the knee out and put a brand new steel one or something like that in there. Somehow reconnected all the bits and pieces and did the same on the opposite side for the hip. There's a lot of, and these tools you use, they are engineered like down to within an inch of their life. I mean, these things have got to be accurate. They've got to be clean. They've got to last. They've got to be of a certain weight. They're engineered to the fine detail. Is that correct?
Oh, yeah, to micros of millimeters, the technical specs are. And then they're tested, like they're extensively tested, bench tested, and then tested and analyzed in the body as to how they function and they work. So yes, it's a very highly specialized area. And I suppose you look at like the NASA space program, like they engineer things to very high tolerances, and medicine is very, very much in the same ilk as that.
And it's funny, like we talk about longevity, and we'll come to that in a moment. But one of the things that will keep us to living longer is just the technology that you guys can roll out. So the technology gets built, and instead of me hobbling around on a bad knee or a bad hip and perhaps falling over or become sedentary because I'm in so much pain. Over a period of time, I probably get depressed and I die. Now what you do is you say, no, I'll give you a new knee, Mark, and I'll give you a new hip, and I'll give you a new shoulder, a new elbow, whatever the case may be. And all of a sudden I'm not sedentary and I can get back to my life and I'll live longer. I mean, there's health tech will make us live longer. Maybe not better, but definitely longer. Is that your observation too?
I think when you look at, it's a fascinating question, because I think when you look at the extremes of longevity, it's been very hard to budge that number. So I always go back to Octavian Caesar dying at the age of 79, probably poisoned in AD 14. So if you look at his death at 79 compared to our average rate of death in Australia, which is 83, and in the US at 79, the actual objective change has been hard to budge. So it's not like your iPhone that you're seeing people living to 300 or 400 years old with that technology. But what you do see, as you say, is the average. So our average life expectancy has almost doubled in 2,000 years, say. And that's an interesting thing. And you're right. If you're in constant pain, a hip replacement is a marvelous procedure. I suppose the question is, can we delay it, or what is the opportunity for us to objectively change that number in terms of the longevity score?
I saw something interesting. I think it came out of this Bureau of Statistics this year. Might have been late last year. That the average age of an Australian male has dropped back a little bit in the last 12 months by about 0.4 of a year. And I don't know why. I don't know what the reason for it is, but it's dropped back to slightly below the number you just mentioned. Females live a year longer for some reason, but the average age of the Australian male before dying is a little bit less than it was, which is sort of interesting when I think about the standard of living in Australia has probably also dropped back on a per capita basis. Lots of things are changing, and it's probably got nothing to do with technology, but you never know what causes these things. A little bit off the topic, but that's just thought I should share that little stat with you. But so I want to ask you this: why have you become interested in? And I hate the word longevity, but why have you become interested in longevity and regenerative medicine? I mean, how does that sort of fit into being a surgeon who's basically there to fix up the problem, see you later?
But it starts with orthopaedics, the recovery after surgery, or the avoidance of surgery. So I was always interested in how you could speed up the recovery, particularly when you get an elite athlete. You're under this pressure that they want to get back on the field very quickly. So then you get down this pathway of minimally invasive surgery, and it seems like with some of those minimally invasive techniques, you can get back to playing quicker, or you can get back. You'd be just.
What does that mean, Gordon? Minimally invasive.
So if you look at a standard operative procedure, so like a knee replacement, it's an open procedure. It's not minimally invasive necessarily in that definition. It's when you're operating through little fine incisions, so they might be 2 millimeters, and you're doing a procedure that might normally have taken an incision that was 5 or 6 centimeters. So then it's image guided with X-ray or sometimes ultrasound, perhaps. And in the US, they've got a lot of CT scanners they're bringing into the operative field as well. So it allows you to operate through very small incisions. And if the incision is small, we infer there that we've disrupted less blood vessels and that there's going to be a faster recovery rate. And that generally holds. So from there, the next thing was, is there any other things that we can deploy in terms of allowing the body to recover quickly after a surgical procedure or just from an injury? And that's where regenerative medicine comes in. In 2020, there was a great article out of Duke University where they published it in Science, where they said that the human body has a salamander-like capability to regenerate.
Well, you should explain that, because salamanders can grow things back.
That's right. So the salamander, the Mexican salamander, is an amazing animal in terms of regenerative capability, that it can regenerate a whole limb. So it can lose a leg and it will regrow that leg symmetrically and proportionately. So, for example, if it gets lost below the elbow, it won't generate a hip and a thorax. It just generates that component. So it's a very intelligent regenerative process. And so what Duke did was look at cartilage cells, hip, knee, and ankle. And what they found is that there's more progenitor cells. There's more of these cells that have the capacity to divide and become cartilage. And they're increasing numbers as you get down the body.
You mean towards more closer to the ground?
Exactly. Yeah, towards the foot and ankle. So the foot and ankle is better than the knee is better than the hip.
Oh, that's interesting. So, and I guess the hand is one of the least likely to regenerate.
The hand has got less. So in some study, there was a paper by Dunn looking at regeneration of cartilage. And you're right, like a lot of people get thumb arthritis, and he found like injecting that with recombinant products like growth hormone, that it took quite a lot in the thumb to get the result compared to the ankle. So it's probably got less. We don't have absolute data on that. But a child can regenerate a fingertip up to about the age of a year and a half. So you can see with humans, we do have that capacity when we're young. We do better regeneration than as we get older.
So your area of specialty in terms of surgery is foot and ankle.
Correct.
Is that right?
That's right.
When you say we have the ability to regenerate, you're talking we as humans, as opposed to being salamanders. Correct. You're talking about cartilage, though.
That's right.
So, cartilage is what, though? What is cartilage?
So cartilage is it's a product. It's a cushion in your joint. It's got two main elements. It's got the chondrocyte, which is the cell, and then the chondrocytes above them make a matrix, and around them make a matrix. So when you load a joint, that is taking the impact. So it's a very highly specialized product. It's subject to enormous pressures.
So, is it like a cushion?
It's like a cushion. That's right. So it cushions the bones. So a joint is made up of two bones, and in between, intervening them, is this cartilage cushion.
Okay, so is what you're saying from that study that you quoted, and what was the name of the study again?
It was from Duke University.
Duke University. Yeah. So, and it was published where? In Science?
In Science.
Science being one of the better recognized journals?
Yes.
Yeah,
that's right.
And I think that's important for our audience to know that sort of stuff. It wasn't just published in some magazine that, you can go and buy at the newsagent. They are hypothesizing, or they've now shown that cartilage lower down can regenerate.
They'll be able to show it, in lab studies. And
so lab studies have shown it, yeah. So that's very interesting. And when you mentioned something, I'm always sort of curious about is growth hormone. I think you said
yes.
Is growth hormone? Can you inject growth hormone into a joint that needs to be repaired or you need to recover because, you may have had major surgery there? Can you inject growth hormone, say, into your knee if you just had knee surgery, or will that affect everything else in your body? Everything else in your body will start to grow? Because once I was talking to a surgeon, a urological surgeon, and he told me that growth hormone if you're a cancer, can actually make your cancer grow too. Is that true?
Well, in some unlikely cancers, I think that would be the case. So the cancer would need to have a growth hormone receptor on it, which can happen in some, but just not that commonly. I suppose the best study that's been done is on a product platelet-derived growth factor, which we use as a product. It's I suppose similar to growth hormone, and we use that, and that was put into the body in combination with a synthetic bone as an adjuvant to get the bone to grow into the scaffold. And they did quite a number of studies, and they got FDA approval. And what they demonstrated was when it's put in localized, it didn't get into the bloodstream so much. The study that you're alluding to is interesting because it's one that we want to do. We need to get approval in order to do it. It has been done by a chap called Dunn in the United States, but he was doing it as an off-license product, and he was injecting growth hormone into joints, and he seemed to have pretty good results. He's got a number of publications. They weren't double-blind, then they're not, I guess, generally accepted. But for what you're proposing, you would need, that would be an off-license application of growth hormone. It's got, its primary usage in Australia is for small stature.
What's that mean, small stature?
So if you're a dwarf, you can get approval.
Yeah.
I think in China it's being used quite a lot, and there's quite a lot of. There's not that much usages of it. I think a lot of growth hormone goes onto the black market, but as you know, like weightlifters and so forth. But because its actual clinical use and approved use is very narrow.
And maybe you could explain that process, because the regulatory environment. I don't want to bore the hell out of people about regulatory stuff, but the regulatory environment is pretty important in terms of what you can prescribe, what you can't prescribe. And for it to get through the regulatory environment, it's got to be approved by the DGA in Australia's case, as opposed to the FDA in the US case.
Yep.
Do you have to adhere to everything that they say? In other words, can you say, well, Mark, you just had this operation. I read this paper in, Nature or something like that, which is, highly, applauded, and everyone in the world is starting to use it. It hasn't really been used here in Australia, but I really want you to get it. I really like you to do it because it might help you recover more quickly. What are your constraints?
Oh, the constraints are tight, and you'd be foolish to go anywhere near breaching them.
So what are but how are you guided as to what you can tell me that I can have? What are your guidelines, and who issues the guidelines?
The TGA issue guidelines. We have a lot of regulatory bodies that we interface with. So, everybody from APRA to our own colleges will tell us what they think is appropriate for us to do. The PBS, or the pharmaceutical schedule, will tell us what is appropriate for somebody to prescribe. So sometimes you can have like an off-license use, but even that,
what does that mean, off-license use? Said that a couple of times.
Yeah, that's what this chap Dunn did in the United States. For many years, he used it as an off-license product. I'm very cautious about doing that. In fact, I don't do it. It's got to have a very well-defined usage before I would use it. And I think that like our regulatory environment is very tight in Australia, and I think you'd be foolish to go anywhere near outside that. For example, a musculoskeletal infection that needs 6 weeks of antibiotics, we are under a guideline that we can only prescribe a week at a time.
So in other words, if I cut myself and at the gym and someone gets infected,
that's right.
It gets into my muscle, or even worse, close to my bone or into my bone. And I come to see you, the prescription will only be a week at a time in terms of the antibiotics that are required.
That's right, a week at a time. We can go outside that by ringing Canberra, and you can get a special approval number. Which, but otherwise, you got to do a week at a time. So you come back, we do another one, or we interview over the phone to make sure you need it. But we know it's in certain guidelines. You need a course. And that's actually recommended within the the prescription guidelines that we have.
So you have to sort of sit around and make sure you're on top of all the regulatory environment, as well as all the diagnostic environment, as well as all the treatment environment, and also the rehab environment.
Yeah, and in some respects, what we do is we exceed the expectation, because sometimes it's grey. Like there can be grey areas, and then retrospectively, a governing body that you might have realised had a hand in that, in the maintenance of that particular thing, come in, and so you got to be careful.
They audit you.
Yeah,
they effectively audit you.
You can be audited. You can, there's a whole lot of different investigative things that can go on from all different sort of regulatory bodies in Australia.
Wow. Do you think that? And we're not here to criticise any regulatory bodies at all. I mean, the system's a system, and if we don't like the system, we move. But do you think that there are other environments which may be getting ahead of us on a global scale, getting ahead of us relative to regeneration and rehab, and maybe even helping us live longer not longer necessarily, but better?
Yeah, well, look, I'd have to say absolutely. There are areas where you can go and you can get unregulated products, Sometimes that could be good. You take an unregulated product into your system. Is that going to be good? It's certainly more experimental, and they've got a lot more latitude to experiment. So the classic thing would be, say, stem cells. So you can go over to the Caribbean and you get stem cell.
I've heard this, Panama and stuff like that.
Panama, that's right. I have patients that have been over there and had types of stem cell that we don't have available here. And there's even there's a really tough environment in terms of even talking about stem cell in Australia.
Oh, really?
Yes, that's right. So it can be that can sort of suppress us a little bit. And I suppose this comes down to the argument. I mean, science divorced from religion in before the Renaissance, and then when it did, it flourished. So now we've got science which is being influenced by regulatory bodies and in some way political agendas sometimes. And how much of that is overreach, how much of that is appropriate? Well, that's something that,
other people make decisions about.
That's right. People that you don't know made the decision. Whereas, when we prescribe a treatment, as you and me chatting about it, and it's, it's very personal. But these are often faceless people making decisions.
So if you're, and you and I talked about this the other day, if you're, let's say you're over 50, and if you're trying to live a really strict life, I mean, I'm talking about in terms of sleep, nutrition, exercise. I mean, when I say strict, I mean regulated life, in order, your objective being that you want to live to much older than, the average Australian male does live. So in other words, you're giving yourself a fighting chance, your best chance. And how important is it in terms of how we live our life out, and particularly how we exercise, that we don't go and break something in terms of the setback we get from these things? So like, I'm a good example. I mean, I've torn my bicep this time last year, off the tendon off the bone. I tore my tricep 2 or 3 years ago. Overreaching. What I mean by overreaching, I don't mean by reaching, but I mean overreaching probably my capacity relative to my age and the person I was competing against. In other words, putting ability, enthusiasm ahead of ability, age related, of course. But how important is it for us to be mindful of this stuff? And you're an orthopedic guy. Like, how important is it for us to be mindful of this? Because, and in that, the setback we get. I mean, for example, my bicep muscle now is shorter than my left bicep, is shorter than my right bicep, and it's probably never going to grow back. Like as we get older, I mean, unless you have access to all these things in Panama, etc., these things, just from observation, I'm not a scientist, but it seems like it's never going to grow back. And as much, it's still as strong or nearly as strong, but it just won't grow. And if we don't grow back, we have a change in our balance between the two sides. I'm different now on one side compared to the other side, and I have to make adjustments as a result of it. How important is it for us to be, as if you're talking to me as a surgeon, is it for me to be mindful of how I train and, how I exercise? In other words, don't go and lift something that's way too heavy.
Yeah, that's a really interesting question, isn't it? Because when you're young, you're sort of pushing through the pain barrier. And if you look at someone like Arnold Schwarzenegger, if you want to be beefed up like that guy, well, you do have to push yourself really hard. But as you get older, you got to start to take notice of things, and you got to adjust accordingly. You can't be a young person when you're an old person without current technology. And as you say, like, you get an injury, and injuries are cumulative. In biology, 1 + 1 doesn't necessarily equal 2. You can get a bad leg and you limp around on, then your opposite side goes because it takes more load. So I think it's very important to be selective. I think it's very important to watch the range and the extremes of movements so I like to do weights. You like to do weights. I think you're better not to go to the extremes of your capability in terms of your range. You need to shorten that down. You need to watch your impact. And particularly, I know that you do a lot of martial arts, and I like hitting against Larry, but I like hitting Larry. I don't like Larry hitting me, right? That's not on.
It'd be scary, actually, Larry hitting you.
Yeah, Larry's a scary guy. He looks like he could really do some damage on you. But it does inspire you to try harder. And I think you're right, you got to get that balance. An injury that sets you back is, you're 6-8 weeks out or 10 weeks, and you become a different version of yourself as you get older. Young people, because they've got so many more stem cells, I think, they seem to be able to adjust to. So an injury when you're younger, say under 20, is totally different to an injury that you get when you're over 50, which is often an operation, right? And that's where you want to stay out of, is having that operation to get better.
Yeah, and so would you say that if an individual over 50 is trying to build a program, as I said, in this sort of strict regime that is exercise, sleep, and nutrition, but on the exercise part of it, does their age inform them as to how hard they go and exercise? In other words, and if you've got a trainer, like I think there's no point when you're over a certain age anyway, maybe 50 is not the number, it could be 55, 45, whatever. It should be, it's individualized. But these guys who say to me, "Oh, mate, I went to failure on every set, and this guy just completely punished me. I was exhausted when I walked out of the gym," and what that informs me of is that, well, if you're that exhausted and you're going to failure, that tells me that your form isn't probably perfect. And form is when injuries occur.
Yes.
Like the people do a back, a hip, an arm, and a shot, a neck, whatever the case. You can do anything. So age should inform us that don't go to a failure and avoid injury in a common sense way. I mean, we don't need to consult our orthopaedic surgeon. What would you say to those individuals about how they should approach their training program?
Well, I would look at, just say you're doing weights, for example, and you're 100% right. You want to have perfect form every single set. And if you get into fatigue and you're wobbling, you don't want to, heaven forbid, drop the weight on yourself. So you would drop down the weight. So if you want to go to fatigue, I'd go to fatigue with a lower weight, for example. The other example where you see that kind of thing happen is box jumps. People jump up onto a box and they're trying to go to fatigue, and the last one they jump down and they're weak, and then they fall over and they break their ankle or they rupture a ligament, or you got to be careful with that, particularly as you get older. But even when you're younger, perfect form is the way to go. And if you want to do that, you want to get that feeling that you've gone to complete failure, the last one should be like just 5 kilos or 2 kilos, like a very low weight with more repetitions, and narrow down that exercise field. So you're doing them sort of closer together maybe.
And can you explain the importance then of resistance work relative to our bone mass?
So it's well demonstrated that you need to maintain you want to maintain your bone mass as you get older. Like you don't want to be osteoporotic, and a lot of ladies get osteoporosis as they get older.
Men get it too, do they?
Men get it as well. Yep. So there's a great law where form follows function. So if you stimulate your bones, they're more likely to remain strong and hard and last longer into your life. One of the classic things that happens, falling over and getting fractures as you're getting older. And that's a great tragedy, particularly hip fractures. Like hip fracture generally leads to, we have this saying, in through the hips, out through the hips. So a hip fracture often is a terminal event, within a relatively short period of time.
Now, I've heard stats over 65, there's a percentage of people who die within 18 months or something like that, or 2 years.
That's right. Yeah. So if you look at, we had this great device called an Ostomy, which was a pretty rudimentary device when you had a fractured hip. And the interesting thing about it, you look at it and from a mechanical point of view, you think this thing's going to fail. But they were very rarely revised. And the reason was that the person died before the revision of them, unfortunately. So you do see that. So maintaining your bone mass is incredibly important.
But how does it work, Gordon? I don't want to get into too much of the science of it or the chemistry or the biology of it, but if I've got, let's say I'm doing a squat, or let's say I'm doing a deadlift, probably more realistic. How does that help my bone mass, say my legs or my hips or wherever it is? How does lifting a weight allow my bone to stay bigger or stronger or more solid or whatever the case may be?
Well, it stimulates there's a stimulation on the bone. So the muscles are attached to the bone. And so then the bone is under stress. So the stress leads to a reaction, leading to Wolff's Law, which is form follows function. So the bone goes, hey, I've got to be stronger. So it then adapts accordingly.
So it's adaptations.
Adapts. But you don't even for the elderly, just going out and walking, brisk walking is very, very good. And
because that's pressure. You're putting pressure on your bones just by dropping your foot on the ground.
Exactly. That's right. So, exercise and motion as you get older, it doesn't have to be that much even. Even they did studies where people just did little jumps on the ground, and they found that led to stimulation of the bone. So there's quite a few things that you can do. But there's the stress, your body will adapt, just like your bones will adapt to that stress that you're doing with the squat, just as your muscles will adapt to they get stressed and they go, okay, I've got to be bigger. And then you get a certain amount of tearing, bones a bit different than that. But then the muscle hypertrophies, becomes bigger, and you get the result that you want, that you're stronger.
So, and I guess the inverse of that, or the reverse of that is that if you don't stimulate whatever the process is through stress on your skeleton, on your bones, therefore the bones over time will say, well, look, I'm not being used anymore. I don't really have any use to you. I'll start to thin, or osteoporosis, get smaller, or get thinner, in which case that presents to any one of us, particularly over a certain age, presents to us a risk, because that particular bone, if it falls or gets knocked or somehow has some other trauma applied to it, could put you in a position where it's broken. Is that how the theory works? Is that how I would roll it out?
Yeah, that's right. So when a bone, as it thins, and you can see this in surgery. So surgery is a classic thing, and that's trying to get people to weight bear early. So we know that, say, for example, your quadriceps, if you take a day off and don't put any load through your legs, so if you have surgery and you can't weigh, then you lose, for every day that you're off your leg, it can take you 4 days to recover that quadriceps mass.
Recover the muscle mass.
That's right, your muscle mass. And then when you go to the foot and ankle and you go to the calf, and I talk to people about this, with calf muscle exercise, once your calf gets wasted, it takes quite a long time to do that. And you look at people like Arnold Schwarzenegger, when he almost lost Mr. Universe one year because of his calf musculature, and then he came back the next year and they said, how's your calf so good? And he went, 280 hours. And he's like 280 is like mindless calf exercises. So some muscle groups, very important for your load bearing and for your mobility, and they waste quite quickly and they're very hard to come back, which is a challenge in injuries.
That's very interesting, because I remember when I had my arm, my bicep tore last year, I had it in a sling for a long while, as you imagine. And but when I eventually got in a sling, it looked like my grandson's arm, like a little skinny little arm. And it took me forever to rebuild it. My strength was like 20% of what it was prior to that, or relative to my right arm, for example.
Yep.
One of the things that I was told, though, and I don't know if it's true or not, that when your arm is in the sling, you can't do any work with it. If you exercise your right arm, somehow it transfers across to your left arm as well. In other words, that's quite beneficial for the arm that you can't use. There is some sort of transfer across. Is that a thing, or am I imagining it, or is that some gym story?
Well, there's a certain truth in that. I think that if you exercise the other one, there is some sort of translation. And if you look at, there was a football team in the US where they just did squats, and they found that they didn't do any other exercise, and found that all of their musculature got bigger just from squats. So there's a certain amount of stimulation, endorphin release and growth hormone release that will interact with your other muscles. I'm not sure of the exact figure of what you would do, but that would be an interesting study to see if we could see that.
And could I ask you, just in relation to resistance work, we don't often talk about the neural connections. So in other words, and all the other glands like the adrenaline and the adrenal glands and those things, are all producing chemicals all the time when you're doing, let's call it deadlifts for argument's sake. How is the neural pathways, and hopefully I'm not asking maybe I'm asking the wrong person, maybe we should be talking to a neurologist, neuroscientist, but you know that there's nervous systems, as you obviously have to move nerves out of the way when you operate on somebody. how do they deal with load when it comes to exercising, and how do you sort of train those neural pathways to be able to accept the load that you're putting on them? Because you go to lift something and it's pretty heavy, and your brain says shit, sends a message straight down to your legs and maybe your glutes, and maybe your grip or something like this is pretty heavy. How important is it for us to train our neural pathways and maybe even give it a rest? Because sometimes I feel exhausted after doing a session, like a weight session, and I feel more exhausted in my mind than I do in my body.
Yeah.
What's that about?
That's an interesting thing. I've got one of our researchers is from Oxford University.
At UTS?
Well, actually privately. So I've got a private group that we research for various things, and this guy's from Oxford, and I was asking him that very question. I think that's an interesting thing. Like even a team that goes out and they look sluggish in grand final, you think, well, what's that about? So it can be like almost a team thing that happens, and you certainly see that with yourself. Sometimes you go to the gym and you feel powerful and you seem to be able to push weights really well, and it is some, I guess, mind over matter type thing. Like if you think you can do it, you sometimes can't do it. And you see that in competitive sports. Now you've done competitive sports. Sometimes you go out and you absolutely nail it and you think I played well. And then other times you go out and you feel, what's the difference on the
These
same
days,
person?
most days I'm like that, but yeah, in competition.
That's right. Yeah, no, and it's an interesting thing. I think that there's something neural. There's probably a combination of hormonal things that are going on in your mind. You had a good night's sleep, other factors that are coming into play. So you're more than just a machine. You're reacted on by various things. So like I find if I go to the gym and I've got something that I'm thinking about or I'm perplexed about and I'm not concentrating, you're sitting there and you think, I've been here for 10 minutes, I haven't done anything. So yeah, I guess what I'm interested in is there a neural pathway that we can develop, or at least get people to find out what allowed them to achieve a really great result in sport or maybe in the boardroom, wherever it was, and then see if we can prep them in that way from a psychological point of view in order to achieve that. And that's something we're going to start to look at. It's our next actual research idea. And I think that you're right. Like some days you're just like fabulous, and then other days you're not. If you watch The Rock in the gym, I don't know whether you've seen him, and he's just yelling at himself, focus. And you get that. Like we get there and we're not focused, I think, is a lot of the time.
Preoccupied.
We're preoccupied. And I think when you look at any of the great sports guys, Djokovic, you see them they're like really focused on the job. Most of them are very focused and they're not so much distracted. And sometimes not very humorous guys, when they're playing, right?
Well, it's because it's interesting because we keep getting told sleep, nutrition and exercise, which it makes sense. But what everyone forgets is that most of us got a job. So let's say we exercise in the morning, and then we've got a job to go to, and then very few of us can, like I see some of the commentators, but very few of us can do 2 or 3 hours, do it whenever we feel like it during the day. We have a regulated life, very structured. We go to the gym in the morning, perhaps, or we might go at night, but if we go in the morning and we have a hard workout, it could be resistance work, could be whatever it is. We also got to go to work and be our best version of ourselves in the office. We can't sort of say at 11 o'clock, listen, lights out, everyone, I'm going to go and have a sleep. Because you might have a board meeting, you could have something coming up, you could have a client, you got to see, who knows what it is. And in our exercise environment, you don't want to neurologically wreck yourself so that you can't do anything down the track. It'd be really interesting to see what your research comes up with in this regard, because I think it's a constraint, because I think a lot of people aren't healthy because they don't go through the exercise environment, because they say, I can't exercise before I go to work because it wears me out. I need to be the best version of myself during the day at work. And then by the time the afternoon comes, you're still working on stuff. And then you're so bloody tired from your work all day, particularly over a certain age, over 50 sort of thing. You don't go to the gym at night, or if you do go, you don't do a proper session because you're too tired. Or you're not at your best version of yourself relative to the gym, which is me. Like I'm the best version of myself relative to the gym first thing in the morning, but I've got to be careful I don't overdo it. And titrating this stuff, like getting it right, it's very difficult, because all we know is what we feel, as opposed to anybody telling us, Mark, you should only be doing 4 sets of 3 at 80% of your max, because scientifically, anything beyond that is going to neurologically affect you, and you're probably going to go to work worn out. And you might get a hit of coffee straight after the gym. You might have your protein shake, whatever it is. It might be good for a couple of hours, but when all that shit wears off, you're going to be subpar. And none of us can afford to be subpar in our work environment, particularly someone like you, by the way, because, if you're operating on me, I want you to be above par. I don't want you to be buggered.
Right.
So what do you think about that? I mean, what would you say to somebody about that? And I know you're not a strength and training exercise expert, but just reflecting on that as a orthopedic guy, what do you think about that and how would you guide someone around that territory?
It's interesting because when I get in the gym, I look around and see people exercise in certain ways, and I think you're definitely going to end up with an injury at your age doing that. They got poor form, maybe they haven't been taught how to do that exercise or whatever it is. And then when I'm doing it, I'm always thinking about, how my joints feeling, and I adjust my weights according to how I feel on the day. So some days, you might find you've done a lot of exercise in the last week or so, and it's a changing environment. Like, as you say, there's one factor, that is constant change, and that is that you're getting older, and as you're getting older, that your capability to recover is declining. And it's not necessarily that it's a linear digression. In some ways it can be, you get these sudden changes as your stem cell number, their capability and their actual physical number are declining, and you mightn't recognize it. So I think that, you need to be constantly monitoring it, particularly what is your main focus. So I front end things. So like, as you say, I find that if I don't go to the gym early on, I won't go at night.
I'm that same.
Yeah. Because you get tired, right? And about 3 or 4 o'clock, your cortisol's dropping off and your body's ready for you to have a nap as you get older, as you say. So, you're hopefully senior enough, you're definitely senior enough that you try to work that important meeting at a different time. In medicine, it's a little bit harder because we're not necessarily got a sort of work environment that is regulated and that things come out of left field. But you're right, we can't have a surgeon anywhere in the world can't have a bad minute. A bad minute leads to potential catastrophic failure. So I would say that, just about every surgeon has their own strategy around it. Most of it comes down to, there's certain things you don't do. You won't go out on a big night during the week, like it's like game night, right? It's surgery's like that's your focus, and it's overwhelming. And then after that, you try to get strategies to de-stress afterwards, because you got to be able to do that as well.
So can I ask you now about, so I don't mind explaining this, but I got an injury in my glute. I can't remember exactly what it is. The glute minimus is torn off. The partial tear, you correct me if I'm wrong, is on the glute medius, and then there's what's this thing? Abductor, partial abductor.
That's right.
Right. So and I did it from falling. I fell.
Yep.
At Christmas time. So. And of course, I walked around for about 8 weeks or 6, 7 weeks without realizing this. But I was wondering why I couldn't sleep at night. I'm an idiot for not coming to see someone earlier. But anyway, as luck had it, our paths crossed, and I saw you. First thing you got me to do was go and get an MRI machine, get an MRI, and an X-ray actually to make sure I hadn't broken anything or chipped anything or fractured anything. Fortunately, there was no hip, bones or structural problems apart from those 3 things I mentioned. What happens when people tear tendons or probably normally tendon? If you tear a tendon, I guess what you're supposed to do is reattach it.
Yeah, well, it depends which one it is. So
right.
You're right, your biceps, that's one you want to reattach, or your Achilles tendon. There's critical muscles that have got to be reattached. And then something like your gluteus minimus, it's a very hard thing, very invasive thing to go and reattach. So you've got to kind of, I guess, put that against the patient's age and their capabilities, and whether it's a new injury or an old injury. Old injuries are harder to get to come back than, newer injuries. So it depends on where it is and how old it is and how old the patient is.
So if it's a partial tear, though, it should heal itself. Is that right?
Yeah, most places in your body, a partial tear would be able to heal itself. depending on your age. Sometimes they're going to become chronic, tendinopathies, and surgeries are indicated, but most of the time they'll heal themselves.
And then there is a protocol called PRP. I don't even know what it stands for, but can you explain what PRP is?
So platelet-rich plasma. So that is where we get your blood and we spin it in specialized bottles. And out of that, we get a concentrate. And within the platelets, there's alpha and beta granules with platelet-derived growth factor. And that's one of the initial pathways in order to get your body to heal. The other thing is that just even plasma. Plasma has 89 million different proteins that haven't been properly identified. Some of those are probably pretty useful in the healing process. So that you can inject that into tendons or certain areas like joints, arthritic joints. And it seems it's an emerging technology. There are studies for it and there's studies against it. My experience is that it's been a very useful product for the management of certain conditions.
So just on that then, I think, and you'll tell me, in relation to tendons healing, we need blood flow.
Correct.
And one of the reasons tendons and even stuff between our joints doesn't heal that well is because those areas don't have much blood flow around them. Yep. And normally your own blood would have all these goodies in there, right, and would heal it for you itself, like if it was a partial tear. Is the reason that you hit the tendon, and believe me, as you know, I've had it. I didn't have it from you, but I've had it from before, and can be quite painful because it goes right into the injury. But nonetheless, I guess the hypothesis behind it is that because there's not enough blood getting around that tendon, we will put the platelets, this platelet-rich syrup. It's a nice. It looks like it's quite thick. Yeah. But we'll put that right into the tendon, so it gets to enjoy what other parts of the body get to enjoy, where there's lots of blood flow. Is that the sort of hypothesis around it? Yeah.
Look, I think when you look at the different theories that are behind it, what I've been looking at is the different modalities we've got, and I put that in a regenerative medicine field, PRP, and I'd put that as a triggering agent. So you've got cells that are not actively involved in your healing. So if you look at as you're getting older, some of the cells that you've got there are, they're not only getting a lower blood supply, but they're also, I call them the gray horses. So you got some cells that are very active and mobile, and then you get what we call cell senescence or stem cell senescence. And so they're like kind of old blokes with a walking frame, and they don't know what they're meant to be doing.
Old cells.
Yeah, old cells. If you can tip the balance, so some of these gray horses become vibrant and alive and get involved in the healing process, then you tip the balance and your pain goes away. So I think that PRP has a number of different effects. I think it's a triggering agent. The needle itself is a bit traumatic, so that the trauma response does stimulate local cells to get involved. And as you say, what things you can do to open up the blood vessels. So sometimes you use like nitrogen patches on the Achilles tendon. It's used in cardiac, angina to open up the arteries of your heart. And what you do is you cut it into a quarter and put that on the tendon, and that opens up the blood vessels, we think. And that also seems to be reasonably effective to help, that group of what we would call tendinopathy, and sometimes that images as a partial tear.
So if you just wouldn't mind helping out me here on this one, often people like me, as we get older, we tend to have a store of anti-inflammatories in our cupboard, and all the different types of anti-inflammatories. And I'm not talking about the ones you buy at the chemist. I'm talking about the ones you get a prescription for.
Yep.
What's the theory behind how an anti-inflammatory actually works? So, let's say I got inflammation somewhere, and I take the anti-inflammatory, the inflammation goes away. But what's that process about? Like, how does it work?
So if you look at non-steroidals or painkillers, they're essentially like a masking agent. They do help with a bit of inflammation, but they've also got a very strong pain-killing action. So you've still got the problem, But some respects the problem might be helped because inflammation is less. So part of the pain is, or the problem is inflammation. But the inflammation is generally a result of something else. So, your joint's a bit arthritic or you got a chondral injury at least. And then the anti-inflammatory or decrease the inflammatory response. And the inflammatory response was like seaweed, the lining of the joint sort of growing into the joint. And then it gets compressed and it bleeds and it leads to this sort of vicious cycle of problems. So it does help in some respects to break that. But the main thing it does is it masks your symptoms.
So if you're someone who's living on anti-inflammatories, by the way, I know lots of people who do this.
Yep.
What's the risk that they're running, apart from gut risk, et cetera? But let's leave that aside.
Yep.
What's the risk that they're running? And at what stage should they go and consult with their physician and or go and see a specialist like yourself about the injury?
So it's reasonable to take them for a couple of days, depending on what it is. But an anti-inflammatory has localized masking things. So you can, we talk about neuropathy joints. They're joints that essentially you can't feel and they break themselves down. And if you're a person that's taking a lot of anti-inflammatories, you're essentially giving yourself like this neuropathic joint type problem. And as you say that, I know professional athletes will often take anti-inflammatories before and after the game to allow them to play, particularly, your footballers that are taking a lot of impact. So that's not good because you got a problem in the joint that you need to take notice of and potentially get addressed. And then as you're saying, like you get the systemic effects. And the saddest systemic effects if you see these medicines are things like when you get kidney failure or liver failure. And because they're often very difficult to reverse once you get them. And you do see that, I get patients that come in that they've got kidney problems or liver problems as a result of long-term use of non-steroidal anti-inflammatories.
So I just want to go back to my injury. It's all about me, of course. One of the things that you advised me to do, well, wasn't so much advice, it's more a suggestion. You said to try, and we'll go down this territory now, there's a hyperbaric oxygen therapy, which is HBOT or hyperbaric chamber. And you suggested that I might try it. I've had a couple of goes at it. And I don't know what, last one I had a go, it was about 4 days ago or something, 4 or 5 days ago. And when I first saw you, I'm a bit confused. I don't know exactly whether this is a proper test, but when I first saw you, I couldn't sleep at night because the pain, well, it wasn't much pain, it was more an ache. It would wake me up after every 10 or 15 minutes on one side, which is on my glute. But I can happily say that as of last weekend, so that's one day after I had my last treatment in the chamber, that I've got no pain. Now, I don't know if that's me healing my own system healing itself, or whether the hyperbaric chamber has helped me, hyperbaric and oxygen therapy has helped me heal myself, has sort of, turbocharged that process. But I definitely feel better.
Yeah, right.
Particularly after last Friday's treatment. Maybe you can explain to listeners what HBOT's all about and what's sort of some of the stuff that's behind it, and what do you and why do you recommend it pre, post operation, pre-operation, and just generally for general health? So
hyperbaric oxygen therapy, it's a chamber, so it's been around for a very long time. So 1662 was
1662.
1662 there was the first pressurized chamber by a guy called Henshaw. Then in 1778, a guy called Priestley came up with the idea of breathing 100% oxygen in order to help recovery from various conditions.
Was it originally there for people who had the bends?
It was later used in the bends, but the first experiments were done just from the pressurization for other conditions, pulmonary conditions and so forth, which they had in droves back then. Then it's been subsequently used in the bends. I think it started in Massachusetts the first time it was used there in divers around bridges. It's you go into a chamber and the data's around about 2 atmospheres. So we go to 2 atmospheres.
What does that mean, 2 atmospheres?
So 2 atmospheres is double the atmospheric pressure that we've got right now. So it's equivalent to if you were diving and you get down to 10 meters. when you dive, you feel that pressure on you when you're in the water. So similar to that. And then the changes have revolved around pressurizing the tank with air. So we monitor the oxygen concentration. We keep it at the same as atmospheric at 21, but you breathe 100% oxygen. Now, according to the physics and laws of gas that we can follow and apply to the individual, we know that then leads to the plasma in your body becoming an oxygen sort of super carrier of oxygen to your tissues. So that means that essentially your oxygen tension in your tissues goes up to 1,200% to 2,000% of what they would normally be. So your hip, for example, a muscle issue that needs a lot of oxygen, it's a very highly metabolic area. It needs a little bit of a push along. I was hoping when you came in, I thought, now you're the sort of ideal guy for this kind of treatment. I'd just like to see how you go. I won't sort of put in your mind it's going to heal it or not. We'll just see what you come up with. And what your body needs oxygen for production of energy. So if you look at the energy cycle, which is ATP goes to ADP, uses one oxygen molecule in your mitochondria. Then your mitochondria are then the powerhouse of your body. So it's like any even economic system, you need energy. If you don't have abundant energy, you're in trouble. And so the energy then allows recruitment of the stem cells. Some of these gray horses change and become more active. And then you also get angiogenesis, so blood vessels can grow in more actively. Cells can move more if they got more energy. But the thing is, you're getting older, like these sort of, like your energy is a combination of the trauma, but also if you had it on this when you were 20, you probably would have had the injury. So it's not just the trauma, it's also the age that you're at. And so I thought hyperbaric oxygen therapy is probably going to help you with that. Certainly won't hurt. And then when you look at the PRP, PRP I think is a very useful thing in this environment. One of the problems around your hip is it's quite a deep structure. It's very hard to actually nail the area and get it into that. And also an injection of a material into your body, that pressure is quite painful. And I remember you saying it was a very painful thing for you to go through.
So the hyperbaric, and I think you did explain to me that the hyperbaric chamber with the oxygen mask that I used at your surgery is medical grade. What's the difference between medical grade and other hyperbaric chambers?
So there's sham hyperbarics, which is a low pressure environment. So lower pressure. So it might go to 1.3, 1.5 atmospheres, and you've got like these various soft tanks. So, and they seem to have an effect, but you just need longer in them. So the other day we were watching the Kardashians, and one of them got out of a tank. She'd been in for a few hours. And if you see LeBron James, there's like quite a few of the Hollywood stars, they're using real science in order to look the way they do. It's not the face cream that they're promoting, right? It's actual true science that they're looking as good as they do. And it does make you feel better, as you say. And it can have unexpected effects on your body. Like you can notice other things getting better as well. I think when I had a diver that came in and he said, I've used, this is just like when I dive. And I've noticed when I go on a diving tour that after about a week, all my arthritic pain goes away. And
really?
He'd noticed that. And I think, well, that actually seems to make sense.
Because they're breathing oxygen too, aren't they?
They're breathing oxygen
through the tank.
Exactly. And they tend to turn up their oxygen and their nitrous down a little bit. They do different mixes according to what they're, how deep they're going and how they want to recover.
Is there any danger associated with it, like the hyperbaric oxygen therapy? Who shouldn't do it? I mean, someone with heart problems or someone who's pregnant, I guess.
Yeah. So we, when you came in, we have a check sheet. So yes, we're pretty detailed in who we allow in and who we don't. We treat most of the things we're treating are lifestyle related or muscle recovery type situations. But there is, if you've got middle ear problems, you can't go in the tank.
So you got the flu, for example.
Yeah, if you got the flu, that is a moderate contraindication. And for our purposes, it's like, you don't need to come in now, come back when you're feeling better. So that's one. The absolute contraindication is if you've got what's called a pneumothorax, you've got a punctured lung. That's it. 100% you can't go in. Not that we would see that in an outpatient environment, but other people that are claustrophobic. And I noticed this when I was in the US and I was working at MD Hyperbaric, that I didn't notice anybody that said they're claustrophobic, but just I'd say 90% of Australians, when they come in, they go, oh, I don't know, I'm a bit claustrophobic. Will I be able to? So we got one with a big window so that we could see people and hopefully alleviate that. But if you're very claustrophobic, you can't go in as well.
Yeah, it's. I should explain to everybody, and we can put up a bit of vision for this. The guys will do that, but me getting in, and sitting in there, but it's fairly noisy in that it's you can hear the oxygen in there, and you're in your own chamber, so everything's sort of vibrating off the walls inside, even though you've got padding. There is a perspex piece over it where I could actually see the technician and anyone else for that matter was standing there, and that took away any claustrophobic sort of environment for me. You have the oxygen mask on, sort of really hitting you hard with oxygen. The process of getting adjusted to 2 atmospheres doesn't happen like that. It happens over in phases. So I went through a number of phases, and the technicians there checking with me and sort of indicating to me, like you should just do. It's a bit like getting on an airplane, and if the plane sort of goes to altitude really quickly, you sort of get that popping feeling in your nose and your ear, and you can just adjust through your nose. But none of that was sort of, from my point of view at least, none of that was particularly prohibitive for me staying in there. Then I stayed in there for an hour, around about an hour, I think, before you sort of let me out over a period of time. So you bring me back down to 0 atmosphere or whatever it is, from 2 to something else. And that's about a 5-minute sort of process. But I stayed there for an hour. I could have easily gone to sleep.
Right.
I didn't go to sleep because I thought, because I was just a little bit nervous my first 2 times. I thought, if I go to sleep and something happens, I won't know it happened or something. I don't know. It was just a bit weird. Yep. But I have to be honest, like I felt completely relaxed in there, like very relaxed. I could have easily gone to sleep. And I actually slept better that night. Yep. I don't know if it helps you with sleep. Is there any research to say it does help you sleep? I actually felt sleepy.
Yeah. So a lot of people report that they sleep a lot better. Every now and then you get someone that says they feel hyper excitable, but that's probably one of the best things. That's one of the things I like about it mostly too. And one of the things about that is if you can sleep well, and you're saying about how you're waking up all the time, about 2 o'clock in the morning, you get a growth hormone surge as part of your circadian rhythm. And growth hormone is very important, like that natural growth hormone to heal. So you get a vicious cycle with your hip. You can't sleep, you don't get the growth hormone, and then it sort of perpetuates. But I fall asleep in the chamber. I love it. I go in and I breathe it in. The oxygen is it's kind of very soothing. Some people find it almost, an addictive thing. I think as you're getting older, like I've noticed, like young people, when they've got an injury or they got some other thing, is very good for them, and they don't necessarily notice some of those other effects. But I notice as you get older that you got areas maybe your brain that don't get enough oxygen, or parts of your body that don't get the oxygen, and you do the hyperbaric, and maybe they're getting the oxygen they need in order to finally get rid of some waste or whatever it is, because your brain is flushing itself out of its waste at night. So it's very important to get that sleep, and sleep deprivation is the oldest form of torture, right? It's a very unpleasant thing.
But that's sort of Guantanamo Bay stuff. Like,
yes, right.
And because it may well be the hyperbaric pressure itself didn't do anything to me, but maybe the fact that I actually slept well as a result of the oxygen within the hyperbaric chamber, that I heal myself through better sleep. Because prior to me going in there, I just wasn't. I mean, I was sleeping, but I'd be waking up every 20, 30 minutes, and what I would find myself having to do is lay on my back, because that was the only way that I didn't get any pressure on my glute. And as a result of that, you're not sleeping properly. Your chin drops. You don't breathe properly.
Yes.
You get a dry mouth. Blah blah blah. There's a whole series of things. This must be a dreadful thing to look at. It'd be really scary for anyone to see me like that. But this allowed me to sleep on my side, and I actually had a bit of sleep, and I was only waking up once a night for the usual reason. But other than that, I've slept better. I don't have any ache or any pain from it at the moment. I think I demonstrated the other day I can now stand up on one leg and take the weight, everything on one leg. And whether it's a sort of a coincidence or could well be a confluence of events, sleeping better, more oxygen, something from the hyperbaric pressure itself, time, and my body doing its job. So the hyperbaric, I definitely would recommend hyperbaric oxygen therapy to somebody else. In fact, I recommend it to some of our players today. So I do want to talk about that for a moment. So in relation to perhaps head trauma, is there any studies been done or any evidence or any even observational evidence that you have come across in relation to TBI, that hyperbaric and oxygen can assist with?
Yeah, so there is quite a lot of studies both in the acute setting and the chronic setting.
But what's the difference between acute and chronic?
So acute's when you've just had the injury and you've got all that swelling and edema, and then the long-term effects are more like the loss of memory and aspects of that. So hyperbaric's being used in both those settings and seems to, in its early stages still, early data seems to be very useful. Not that I would think that, it's going to be a substitute of avoiding the head trauma in the first place, but it does decrease the edema. And I think with your initial concussions and things that you get in rugby league, that you're seeing people that have got like a lot of swelling and they've got the headache, and they need to do all the protocols that are being recommended, avoid playing, but it could help with the symptoms and maybe help with the recovery of that.
So we've actually sent one or two players up there. In fact, we had a couple on the weekends. I was talking to the coach this morning. He's actually going to talk to our head of rehab to perhaps contact you guys to get the other two guys up there this week. When you do this for HBOT protocols, how often do you have to do it? Like, I've been doing it once a week, but as I understand it, it's a different to be most effective. What's your optimization? Is it daily, every day for a month, or what is it?
Yeah, well, it depends on what you're going to treat. So some things that are like I look at things that are slow metabolic organs that you've got, they need a lot more treatments than something that's got a very high metabolic rate, I think. So for example, yourself, I thought, I really hope Mark's going to notice an immediate improvement. You see, you're in intense pain. You see that, you were tired and, you had all these things that were sort of, and you're worried about it. And so I thought, hopefully this will make a big difference for you. And then you go from that where, maybe one or two, you might see a difference, hopefully. And then you see other things that you need quite a lot of treatments for. So there's very well-defined scientific protocols. We interface with MD Hyperbaric on their protocols.
Who are they again? MD Hyperbaric.
MD Hyperbaric. So Matty's set up, he's got about 5 clinics, I think, in the United States now. And they've got a couple of chambers in there, one in New York. So we've adapted a lot of our protocols from them. And then, the other protocols we've got just from the scientific literature. So, for example, there are protocols for infection. So if you have an infection, you might go in for an hour and a half.
Like a blood infection, for example.
That might be a bone infection, for example. So osteomyelitis, there's protocols for that depending on what it is. And that's an hour and a half every day for a series of treatment. Some treatments, so there's longevity programs where you do 40 treatments. And then you do maintenance treatment after that.
40 treatments.
40 treatments.
40 consecutive days?
Yep.
I mean, do you take the weekend off or?
You take the weekend off, yeah.
Yeah, so you do 8 weeks of.
8 weeks.
Yeah.
Yeah. We've had a couple of people that have come in and they've actually been going to other units that come to us and say, oh, I want to pick it up. I'm on holidays in Australia and I want to keep going. It depends what you're trying to achieve as to what you would do. So a surgical protocol, which is based on a study that was done in the United States with plastic surgical patients, was 5 treatments, 2 before and then 3 afterwards seemed to be what they suggested was good. So we follow those. And you do bespoke it a little bit to the person. So, if people come in and they say, look, I feel fantastic after a few, you might go, well, maybe you could delay the next ones and do them later. We do try to keep people adhered, but compliance is a bit of an issue too,
Yeah.
coming in every day for an hour.
Not easy.
Not easy, yeah. So compressing those treatments, I think, will probably be our next thing to look at, is because like everybody's time poor, right?
Well, we allege we are. It's all about prioritizing, but that's putting heavier weight on certain things that we traditionally don't put enough weight on.
Yep.
But what I found interesting there is that there are different protocols in terms of the use of the machine.
Correct.
Relative to whatever it is you're trying to achieve. So if it's a longevity issue, in other words, a freshen up, a retune.
Yes.
We're talking about potentially the protocol says 40 treatments, for example. If it's a bone infection, it could be, some other protocol.
That's right.
If it's a pre-surgery, I think you mentioned two prior to surgery and 3 post-surgery, something along those lines.
Yep.
And these protocols are being developed in the US under, I guess through their research. And you're sort of borrowing the protocols here in Australia.
That's right. So we look at published data, like peer-reviewed data. In actual fact, the Israelis are probably one of the most advanced with hyperbaric. They've published a lot of data, and they've even published data where you do all these treatments where you talk about, longevity. One of the things, there's 14 scientific things that happen to a cell as you get older. One of them is the telomere, which is a little bit of genetic information on the DNA double helix, which gets shorter as you get older. And they've done studies where they've done their longevity. These are where their longevity sort of studies come from. And they can actually see in some cells that the telomere length is lengthened with their treatment, which is amazing that it's had that effect. So these things are in evolution, they're developing. So we kind of borrow scientific data from everywhere in the world as it comes available.
Oh, that's interesting. So the telomeres in some of the work they're doing, they've seen instead of the telomeres shortening as we get older, they've actually managed to lengthen or at least arrest the shortening.
Yeah, that's right.
As a result of using a hyperbaric chamber.
Yeah,
and that's an example. I guess that's an example, Gordon, where that's a longevity outcome, because you would expect as we get older, we get shortened telomeres, but if we can re-lengthen them, then it would sort of follow that that individual may have the potential to increase the length of their life as a result of these telomeres, not sort of reducing it down to just about zero.
Yeah, and that's like we in medical school we do comparative anatomy, and I talk to our students about comparative longevity. So we look at different species that live a very long time. So, an American redwood, which lives hundreds of years, you look at its cells, its telomere length is maintained. So we know that seems to be important. It's probably one of the it's probably not the only thing.
It's a marker.
Yeah, it might be just a marker, but certainly, as we talk about this peril of replication. Every time your cells divide, the telomere is shortened each time. So maybe it's used in that change. And if you don't have it, you're more likely to get an encryption error, and then that leads to a bad series of steps for your body. But whether it's going to be it's just a marker or it's like really important, I think we're still early on in that in studies.
So if I could just go back to surgery for a moment. And I did say to you, like, if we've got an injury, we've got to go and talk to a surgeon about what should we do, or at least talk to our doctor who might refer us to the specialist who might then refer us to the surgeon, because that's sort of a different process. Because normally what happens is, as I understand it, is that you might go and see your GP. The GP sends you to an orthopaedic specialist who might not be a surgeon. Sometimes they're not the same thing, aren't they? It's a bit like going to see a neurologist who might not it might not be a surgeon, or a cardiologist who might not be a surgeon. But they sometimes then, if you got some problem, they send you off to the surgeon. There's a different part. Is that the same operating in orthopaedics?
Not generally. There are some orthopedic surgeons that retire and they keep consulting, which is fantastic because they're great to they've got enormous experience to get second opinions from.
So diagnostic though, more than it.
There's not that many. So most orthopedic surgeons, just about every orthopedic surgeon still operates.
Yeah, right.
And that's so it's a little bit different to neurologists and neurosurgeons,
Okay.
I guess, in that respect. We have an arc of people that specialize in joints, rheumatologists. So they don't operate; they prescribe medicines, and they take over there's certain joint disease which is not surgical; it's medical. So rheumatoid arthritis, for example, is largely a medical treated disorder. There's also sports docs. So you've seen sports docs, and they can be like above, in terms of musculoskeletal definitions, above your GP and before the surgeon. So, and they generally, they often do like interventional things like PRP injections, and they coordinate your treatment with your physio.
Yeah. So in Australia, do we get much? Let's call it overservicing then. Is that a thing? I mean, I have heard of it in terms of a good example is prostate biopsies. I mean, That's a big deal, has been a big deal around the world. I mean, there's been articles written in the New York Times about it where people are going for biopsies because the MRI that they had on their prostate was equivocal, as opposed to unequivocal.
Right.
So in other words, it wasn't less than 2.5, but it wasn't more than 4.5, which 4.5 mean it's unequivocal. In other words, you more than likely got cancer. You got to get it. Got to go and find out how bad it is. Or if it's under 2.5, it's still unequivocal, which says there's no way you got cancer, but so we don't need to do a biopsy. But if it's somewhere in between, it's equivocal. Somewhere between 2.5 and 4.5 in terms of the measurement. We don't know. So the choice is up to you. And of course, everyone's going to go, oh shit, maybe you don't know. I don't know. Maybe you better do it. And there's been some talk about overservicing. Just that's an example in terms of prostate that I've read about. But in terms of orthopaedics, is there much overservicing that you know of, and that other alternatives could have been used instead of having surgery?
Look, I really don't think there's much overservicing in Australia. Like, I think that we have most of my friends are surgeons, and even guys that I disagree with, I know that 100% from a higher level, they're trying to do the right thing by their patients.
Yep.
Overservicing, if you get a bad result, it's a really bad outcome for the person to begin with, but it's also a very bad outcome for the professional. So you want to be doing your best to get very little chance you're going to get a bad result, and that comes to getting the right indications. So,
but at what point do you start? What point do you say, let's try all these things first? As opposed to going and doing surgery. Like, how does that process work? Like, come, Mark, let's do hyperbaric, let's do PRP.
Yep. Let's
not go straight in and fix it up. How does that process work?
So it comes down, the first step is diagnosis, and then putting that diagnosis, what the likely outcome is. So we always like to go back to the root cause analysis and then try to look at the natural history of that disease. So, for example, if you go to the idea of the prostate and you say, well, there's a chance that this could be a cancer, right? That's a really bad outcome for you. So then you might be more likely to intervene to make sure you don't have that. When it comes to orthopedics, you're talking about lifestyle surgery. So you generally don't have that pressure that you got to, when you look at indication, the absolute indication and, a facelift that you never actually ever have to have. So you're doing it from a lifestyle point of view. So orthopedics is always in the middle of that. So it's, if you've got, for example, an arthritic joint, you might say, well, an arthritic joint, we can try all of these things. You might say, well, I've already tried those. I've tried the physio, I've tried this. And then you go, well, do you really want to play rugby, or do you really want to do some high impact activity? Can you give that away? And you might say, no, I really want to do that. So then that comes down to collaborative consent with the patient, and then you sort of arrive at a decision together. And as you say, that can be frustrating because it's a bit like the pilot coming out and saying, do you want to tell me how to land the plane? Like, to a certain extent, we have to, we're guiding and we're trying to be conservative, but we're also trying not to be overly conservative and leave you in, pain for a very long time with the knowledge that the conservative measures just aren't going to work for you.
Yeah, because, a good example is what you just said about arthritis. I remember once I went to saw a sports doctor about I've broken my thumbs on a number of occasions, and it's pretty common to get arthritis there anyway. And he said to me, the two alternatives are, well, first I'm going to try. He put some sort of anti-inflammatory into, like what do you call that stuff?
Steroid.
No, steroid.
Yep.
And oh my God, talk about that did hurt straight into the joint, right? Which is really already sore. Yeah. And he said, look, if that doesn't work, what we can do is we can go to see a hand surgeon and get it fused.
Yep.
Get the thumb fused. So I presume that means I'm never going to be able to use my thumb again.
No, you'd be able to use your thumb, but you would lose some movement.
Yeah, so probably my grip will be affected or something like that.
Yeah, it could be. Well, it could be like if you're getting lots of pain, you got a weak grip. So if that pain went away, then your grip could actually strengthen. But it is, I guess what you're getting at is that the treatment by its own nature is going to leave you with a disability compared to if you never had the injury before. And I think that is an interesting question. With regenerative medicine, we did a little discussion paper saying that we need a paradigm shift in how we measure outcomes. So our classic thing with outcomes is you come in, you got a problem, we do an operation, it could be fairly invasive, you're not that happy about it, but at the end of it, we've got a good technical result and you're better than before. Compared to what do you like? Is our outcome measure compared to if you never had the operation and someone that never had the arthritis? So that's where regeneration or reversal of the disease process comes into its foray. Is that possible even, or can we start to move towards that?
Is it true? And I don't know. It's one of these myths that we in the health world. But if you've got an arthritic joint, that you should use it. Or if you stop using it, the arthritis just gets worse. I mean, in other words, use it or lose it type of thing, So, I'm someone who has, because I do the jiu-jitsu, my grip's really important to me. Like I've got to be able to grip the gi and stuff like that, or grip someone's elbow. And I just think that suits me. There's someone to say that that's actually what I want to hear, I suppose probably not what I should be hearing, but what I want to hear. And therefore I think, good, just use your hands, Mark, use your thumbs, which I find it difficult to use my thumbs, but use them and then your grip will get stronger. And as a result of that, you'll perform better in your jiu-jitsu. Is that true then? I mean, if I've got arthritis there, I should keep using it or does it just aggravate it, make it worse?
If it's giving you pain, like if you had a joint problem and you're using it, it's giving you pain, it's probably damaging you, particularly within, your young age bracket. Right? So when you're younger, it's so it depends on where you are. So for example, and what the injury is. So when you're younger and just say you have surgery, just say you got a shoulder stabilization procedure, you want to get some movement back, you have to, your physio produces a bit of pain, but you don't have necessarily a joint deterioration issue. You're working on a movement problem. When you look at as you get older, it changes a lot. So I get it with foot and ankle problems a lot with the physios. You get someone in their 50s, 60s, and you send them to a physios in their early 20s or late 20s, and they go, well, if you move like me, I'll have solved your problem. But it's not that. In some respects, stiffness is of benefit to you, and you want that. The worst thing you can have is an arthritic joint that's hypermobile, because it's breaking down. So your body makes your joint reduce its range of motion in order to protect the joint, because those extremes we were chatting about before are not necessarily good things to try to entertain. But with you, if you've got thumb arthritis and you're there and you're getting pain and you're wrestling, you're damaging those joints. A little bit of movement's good. So generally we look at movement with an arthritic joint that's linear or within its capable range of motion without weight and is non-painful. So for example, ankle arthritis, I try to get people that are doing regenerative protocols to get on a stationary bike without any resistance and try to do that 15, 20 minutes per day.
Quite linear though.
Yeah.
You're not going sideways, you're just going through the same motion.
That's right. We used to have machines that were called like CPMs for the knee, continuous passive motion machines for after surgery. And I think that is pretty useful, for trying to rehabilitate arthritic joints. With your thumbs, a little bit more difficult, but But I was hoping you were going to say, do we have any other tricks that we could use for your thumb?
Do we?
Yeah, we do. So, with the thumb, generally I do like hyperbaric and then do PRP. But the PRP, as you say, it can be quite painful. I tend to use quite a lot of local. The body doesn't like to stench-in. It's got a lot of nociceptors, which are identifying areas of your body where you had an increase in pressure. So injecting straight in the joints, you're right, it's quite hard. So I tend to use a lot of local, and I tend to do the injection a bit slower. Because if you're going to be a candidate for that type of surgery, it's got to be comfortable. Otherwise, you're going to run a mile when you see me. It's got to be, we've got to be on speaking terms after the treatment, right?
Yeah, I can't be so horrified that I'll never come back.
That's right. You'll never come back.
We often hear about grip strength as being a marker for longevity. Do you have a view on that? I mean, I've heard lots of longevity experts talk about this as to grip strength, and therefore, obviously, everybody's running off trying to improve their grip strength. There's lots of ways to improve your grip strength. Just holding the bar or farmer's carries or whatever the case may be, using a grip machine. Would you have a view on that about grip strength and longevity?
Yeah, look, I don't have a firm view on it. Like I can't point to a scientific study to validate that as a concept, but it's certainly, the stronger you are, I think that it's very important to be strong late in life because you know that you're going to deteriorate. There was a study that was done, interesting, getting up from the floor, and they timed people getting off the floor, and if you didn't get off the floor within a certain amount of time, they correlated that with death in the next,
So there's a correlation. It's a statistical correlation.
There was a statistical correlation in that study. I think, though, that when you're looking at grip strength, probably a stronger person, maybe they are going to live longer. Certainly, as when you're sick and you're not going so well, you're going to have a weaker strength. But a lot of the elderly people that you see, they're living well into their hundreds. They don't look that strong to me. I think there's probably the most important thing is going to be your stem cell and your genetics that are playing a part. Even with arthritis, so the main thing with arthritis is as you get older, you're more likely to get it. So chronic disease is directly correlated to getting older.
Yeah, it may be perhaps the way I should have put it to you is, as opposed to being like super strong, it's grip strength is a corollary to frailty, and frailty is probably, I don't know scientifically, but it just makes sense to me. If you're frail, there may be a greater correlation with frailty and passing away earlier. Because frailty is no good. You're going to fall over, something's going to happen, or you can't move because you're so frail, lack of movement, etc. Perhaps you age quicker. But so, the opposite of frailty is grip strength, like strength. And maybe that's where it's going to, by the way, because, people who I see are older in their 90s, their last decade, who get around well. When I say they have good strength to get up the stairs here, I'd had old Harry Triggerboff here a couple of weeks ago. Harry got up and down those stairs, no problem. He walks from here to, he can walk a couple of kilometres, no problem. He's 90, just turned 92. When I shake his hand, I can feel strength in his hand. He doesn't have Tarzan grip, but he's got a strong, firm handshake. And, I wonder, everyone I know, my own father, like up until the day he died, he was nearly 90, he had an incredible strength in his hand still. Even though he was physically sort of, not much of him, but his forearm and his hand was quite strong. And I just wonder whether these things that we keep hearing about, they're probably more observations by people, just like I made an observation then, and therefore they become sort of a little bit folkloric. Like if you want to live to 100 or 95, or whatever it is, you have to be like Harry. Or you have to be like my dad. And one of the things we notice about Harry is he's strong. He can get up the stairs. He's got strong legs. Mark, your father had a strong grip. Because no one's really studied anyone to their 100 and sort of, they didn't follow them from the day they were 10 to the day they were 100 and do map out, do blood tests every week and, grip strengths. And, no one's ever really done such a long-term it's called longitudinal, I guess, but a long-term study on these individuals as to find out exactly what it is. And it'd be fair to say these observational science has become quite prevalent in this whole longevity discussion.
Oh yeah, there's a whole bunch of different factors that come into play. I mean, from diet to geography. I mean, it's interesting that Australia, is ranked 6th in terms of longevity. We do pretty well. And then if you look at, there's been studies done in like the Mediterranean and the diet, and so there are a lot of things that seem to play a role. When you get down to it, like say about Harry Triguboff, you like animate a guy, like his brains, when you see that genetically, does he have a purpose? Is there something else going on there? I think they could all play a role. Certainly being strong, I think you're right. I think as you get older, you want to, I think resisted weight exercise is very good as you get older. You need to be able to get off the floor. You need to be able to have your mobility, and all of those endorphins and so forth that you go back all do feedback to your brain, and also the blood supply and the oxygenation of your brain. All of these things play a role. I think they're important. Giving you an exact figure of the science of what you should do. I don't know whether you just have one of those group things, whether you did that every day, whether you would live longer. I think that most of the things, when you look around, that most things like that we might go into, say, a biohacking, the citizen science of longevity. I think you look at a lot of those things, I think they do make a bit of a difference in terms of how you feel. I don't think if they were going to make a big difference, you would have found someone that ate a particular vegetable that lived 300 years. I don't think we're seeing that. And I think that most things have been tried. I think that if we're going for a big sweep in, people living to 200 or 300, that we're going to be looking at something different. And I think it's going to be like real science. And it could be already around. Like if you look at the Wright brothers getting out of the plane. Well, all of the components we'd had for many years. It just took someone to put them all together. And at Kitty Hawk, you get a plane that lasts a little bit. And then from there, we've made a lot of distance. We need that initial breakthrough, which I don't think we've seen yet. I think that we can see some things that seem to have an effect. Certainly you're seeing like, when we were young, if you went to the movies, you wouldn't have seen a Hollywood starlet. The 50-year-old Hollywood starlet is now looking great and doing she's the sex siren and so forth.
Well, they look younger than they did 25 years ago.
Yeah, no, it's amazing. So you're seeing it as an external thing, like incredible things, or even, Marlon Brando, he wasn't like a action hero. He had that older statesman role. But now Tom Cruise can get out there and he can be, what are we up to, MI-15 or whatever?
He's only 60.
Yeah, so he's doing very active related roles and still doing his own stunts, right? So I think we can see green shoots. We can see where it can be, at least in terms of life health, rather than life expectancy. We can certainly see people that are very active and doing a lot of things you would have thought 30 years ago were pretty well impossible. So we're seeing that. But no, I don't have a figure on. I mean, it'd be great if it was just like you got this magic grip strength, you did that, you get an extra 50 years. I think there is something in terms of, your virility and your strength is very important to maintain. People that I see in my office that are very young, they have a component of things. They have, they might be, secretly doing the Botox and doing the vampire facelift and doing PRP and various other modalities, but they also act young. And so it's like that Sophia Loren type idea, keeping the old man out, might extend your life, but certainly you seem like you're younger as you're getting older.
Hey, I'd like to finish off with two more things, but one thing in particular. I grew up in an environment where you never stretched before you trained. In fact, you never stretched at all. But then stretching became a thing. But then more recently, I've been reading about and listening to that it's dangerous to stretch before you do weight exercises.
Right.
What's the deal with stretching? Like, you're an orthopaedic surgeon, so you know how important it is to get muscles to be pliable and flexible. What's the deal about stretching? Is it a thing? I mean, do you do it separately? Do you have to do it often? Should you do it after you train, or we should just dedicate a day of the week when you do stretching, maybe in the form of yoga or your own body weights?
Yeah, so there's two types of stretching, the dynamic and the static stretching. I always think whenever it says stretching, I always think about the dog in the morning when you get in, you wake them up and they go and they do that big stretch and a big yawn.
Down dog or up dog, which one? But they do.
that's
My
right.
dog does.
Yeah, that's right. You think, well, the dog just intuitively does a big stretch before he gets on with the day. I think that when you look at stretch, it's a bit overrated, I think, but I think it's important if you're cold that stretching and putting your joints through a range of motion, this thing called proprioception, that the joint needs to understand where it is in time and space, and your brain has a bit of an idea of feedback on what it's doing. I think stretching is good for that. I think stretching is also very good if you're starting to get certain contractures. So some people, you see them getting older and you see the way, as senility of gait, when people are walking and they're sort of all bent over.
Wobbling.
I think that having a joint that starts to get a bit contracted, I think that's good to stretch out. But I don't think that it is, I don't think it's an absolute. I think it's a good thing to do, but I don't think it's going to protect you necessarily from injury.
That's interesting because, I don't know whether I'm being an old narc and just saying it's overrated and that, I see stretch gyms around the place and good on them. Some people might like them, but I don't know whether it does too much. I've tried it. I don't know if it's really I haven't had any overwhelming positive experience from it. I get it, like if I feel my muscles contracting. And like you say, the first thing in the morning, I definitely do stretching. What about things like Pilates? That form of exercise. It's not weight bearing, but how important is that? Because I have spoken to some physios who recommend that after you've had an accident or you've had an injury, things like Pilates, it's sort of doesn't put too much tension on you, but at the same time seems to build strength.
Yeah, so I recommend a lot of my patients do Pilates. I think it's an enormously important thing. A lot of it came from World War I, where a German physician found that he couldn't get his patients. They used to put people in bed for very long periods of time, and then they couldn't get them out. And then he devised a series of exercises that were all based on the core. And I think that when you look at our society, we tend to have poor core, and you see people who are sitting there, their sort of stomachs are sticking out, and they're using their back more than the muscles in their abdomen in order to maintain their skeletal alignment as they're walking. So I think Pilates is fantastic for that, and I think everyone should have some sort of core element to their training as they're getting older.
That's very interesting. I used to, I don't so much have the problem now, but I used to always notice if my back was sore, it was because I hadn't done enough core work. And when I started doing more core work, my back used to improve.
Yes.
Is there a relationship between bad backs and abdomen?
Yeah, definitely.
Strong abdomen.
You want to be using your abdomen more than your back. So you want to get those muscles always firing and always holding you. It's the classic thing when you see, soldiers at attention, your chest out and your stomach in. It's really important for your back. It protects your back. And as we're getting older, all of us have got arthritic joints within our back, and the muscles, if you use more of the muscles at the front, you'll protect those arthritic joints. So you're right, if you lift something and you're not braced correctly, or you don't hold your core, you'll use your back more, and then those joints will flare up.
And I think that sort of brings us back to lifting weights, for example, or is that one of the things we've got to be sure of is that we have good form, and good form usually means engaging your core.
Correct.
Otherwise, you tend to get an injury, and then if you have an injury, you get setback. Especially as we get older, we get a setback. My final question to you, and it's a bit out there. I was only just thinking about it this morning, though, and you may not have an answer on it. But do you think that one day, using artificial intelligence and machine learning, that we will be able to construct using one of the protocols? I don't know whether it's ChatGPT or Grok or Copilot or Claude or one of those AI protocols, that we might be able to get those protocols to build for us like an algorithm as to what are the elements or the variables, probably a better way of putting it, and what's the weight in relation to each variable that allow us to live our longest, best life. Like we're going to be, maybe we're going to need a supercomputer to do it for us, and we need a really big data set. But can you see that happening? Because it seems to me like there is no one individual, no longevity expert out there who's ever said, look, because someone will say on one hand it's more exercise, someone will say it's sleep's the number one thing, someone was going to say, and it's food or whatever, but it's different for everybody. Every individual is different. Yep. And therefore, if we could get some algorithm that we then could put our own particular variables into, we can get let's call it a customized best outcome for Mark, or a best customized outcome for Gordon.
Yep.
Do people ever talk about these sort of things? Do you ever go to longevity conferences where this stuff starts to get touted?
I think that I think that's probably the aspiration of something like Neuralink, isn't it? That you'll have a chip and it'll be monitoring various factors. I mean, you can do it. You've got the watch, you got the watch, which is monitoring your blood pressure and your pulse.
I'm wondering whether Whoop's doing it. Like, so on this app, that's what makes me think about it, because I look at this every morning and look at my, my HRV. I'll look at my blah blah blah, all the various things that comes off this. And it's getting, and the Whoop app is getting much, much, much more sophisticated all the time, and it's learning more and more about me. And when I look at it, I'm learning more and more about myself.
Yes.
And I'm noticing that and I don't know whether I'm talking myself into it, but I notice myself that I want to have a good sleep. And maybe as a result of being in the hyperbaric chamber and getting stacks of oxygen, that my pain is starting to go, which means I have a better sleep, which means my heart rate variability starts to improve. And overall, I'm improving everywhere. And then I'm thinking, well, hang on, I wonder whether there's some sort of algorithm here that I could build myself. And I start thinking to myself, this bloody thing is probably building an algorithm on me anyway.
Yes.
Do people talk about this sort of stuff in your profession, like, as doctors and surgeons and as medical people?
Yeah, I chat to some of my colleagues about it here and there. And I think looking at work done by David Sinclair, various other people.
David Sinclair, the Australian who's in America at the moment.
That's right, at Harvard. So you do see a lot of people postulating what could happen in terms of getting to an objective change in lifespan. And I think that, that might be part of it, is the measurement of it. So you're saying about, we start off with diagnosis, that how do we make a plan as to what you need, and how would we analyze that? It'd be interesting to see the biomarkers that you could potentially would be very important in that. And then that could lead to a cascading series of treatments. So, for example, I know that there's, I've got a friend who does stem cell, not here, but overseas, and a lot of people are having stem cell infusions. And so that might be something of it, that you get a replenishment of the cells that you need, that are really important, apart from just, say, growing organs outside the body and replacing those, which might allow some conditions to be treated rather than you actually living longer. So I think it's possible. What it will be, I don't think we necessarily know what those markers would be. I imagine it's going to be something at a cellular level that we're going to be monitoring, something like the DNA degradation, and this chip or whatever it is will measure that, and will say to you, okay, now you need to go and have XYZ treatment, or we're picked up that you've got a problem with this particular organ, and from your biomarkers, and it's happening all the time. At the moment, for example, when we've got some interventional things, and you go to your GP and you get your stool sample, that to look to see if there's blood there. That's always a confronting thing that the government hit you with as you get older. So there are some things that we're measuring, and there's a lot of things we're not measuring, and perhaps we could be measuring those and then doing interventions that are happening that about, and so you don't have to physically initiate the test. It's sort of happening automatically. That would be a great thing if we could come up with that.
What's your hope for longevity, or the world of longevity? What do you hope will happen in your lifetime?
I don't know, it's quite interesting in our lifetime. So, we were chatting about this a couple of days ago. We were saying, statistically, 12 years or 15 or 20 years, can you ignore it? Well, I suppose you can ignore it to a degree. I'd like to think that, number one, that we can work on life health. So life health, I think, is attainable. I think it's here. Maybe we can avoid
What's
surgeries.
That mean?
So how you're living, so that you're active and you're fit. So wouldn't it be great if you're, as you're saying, you're 95 and you can run a marathon, and then you maybe you don't live past 100, but you're very active until that time. Certainly your mind's active. So, I think that in my lifespan, I think that I'd like to live a long time and see grandchildren, those sort of things, and be active, and my mind being active, physically active in that time. An objective change in our lifespan, I think we're not there yet. And I think it's going to be one of those things. I think we're probably, frustratingly, we've probably got all those things at our fingertips right now.
It's a bit like the Wright brothers.
We're like the Wright brothers. I think we're like the Wright brothers. We don't know how to put them together. I think they're probably there, and I think that we'll get there. I don't think that we're naturally, or we're going to absolutely have to die at the rate that we do now. And I think there's no real problem with extending to 200 or 300. Certainly, you see it in comparative longevity that animals can do it. We're sort of a bit frustrated in it. We won't be able to do it without real science and real intervention. I don't think it's going to be like a vegetable that you eat or a diet, or even though diet's very important, I don't think that's going to be the thing that's going to do it for us.
Well, that's very interesting, because there are people out there now who are selling these things.
Yes.
And because it's really confusing, most people, and I'm one of them, and the more I know, the more confused I get. Most people like me think, well, may as well just try these things.
Yep.
But the question of you're not going to try them for a lifetime, because by the time you try it for a year, something new's come out, and you think, well, wait a minute, I should be doing that. And then something new comes out, and you say, wait a minute, I should be trying to do that. And I tend to bounce around the joint, and it is frustrating, which is probably the reason why I'm doing Project 100, to be honest with you. Right. Is to have an opportunity to talk to people like you and various other people who we got on the show, and got lots of different people coming up on the show. I and my team and myself, we want to expose from leaders in the medical profession like yourself, and people who are also in the medical profession who's prepared to be brave and courageous and try new things like HPOT, but not that you're inventing it, but you're bringing it from somewhere else. Protocols from other places which look like they're working. Bring those things to Australia, and maybe just through observational science, just see outcomes, watch outcomes. Not necessarily measured science, but at least observational science, which is what I was trying to say before in terms of my own experience in your hyperbaric chamber. We need more people like that. And the show's about me exposing the public to more people like you, instead of us just sitting on our hands and just doing what we've always done. I think doing what we've always done is going to get the same outcome. We're going to have the same outcome that we've always had.
Yes.
People die at 83 or 82.6. And I don't know if people really want that. Young people probably aren't that worried about it, but when you start approaching that period, I can assure you it is a short time. Yeah, and you think, oh my God, this is not right. This is not not that it's not fair, but you think, oh my God, why hasn't someone done something about this? And this show is about just teasing that. And what you've done today is you've exposed us to HPOT. There's lots of things we need to be exposed to, but we need to continually tease the system, and we need people who have enough courage people like you have enough courage. We'll have courage. We'll try it, but we need someone like you to bring it here for us to try, because we're not going to go to New York and meet the dude over there. And, we have no access to these individuals. We don't even know who they are. Yep. So we need more of this, much more of this. Australians, the rest of the world too, but the Australians, as far as I'm concerned, we work hard. We deserve to live as well and as long as we possibly can. I actually think as a government policy that should exist in this country, that it's not about just working hard and retiring at 65 and you've got some super. I think government policy should extend to making sure that Australians can live as well and as long as absolutely possible. We should be trying to achieve that goal. No other country should be able to outdo us, and if they are outdoing us, we should be looking at what they're doing and how can we copy that or adopt that into our own system. And that's what Project 100 is about.
Yeah, right.
To get the best possible outcome for every single person who lives on our continent. That's what I think Australian governments should do. And if by the way, any government puts their hand up for that, you win the election. Gordon, thanks very much. Dr. Gordon Slater.
Thanks very much, mate.